In this presentation, we'll be discussing pharyngeal and laryngeal disorders. This lecture was written by Dr. Beverly DeGranchamp. Dr. DeGranchamp is a board-certified family nurse practitioner and has a doctorate of nursing practice degree. She's been a nurse practitioner for 18 years and has been in the nursing field for over 40. She currently does local TENMS assignments all over the nation and has worked in a variety of settings. Narration of this lecture is provided by Dr. Tracy Murray. In this lecture, we'll be examining pharyngeal and laryngeal disorders. Not all ENT topics relate to throat complaints, but we'll cover several of the most commonly seen in primary care. These discussions should provide you with a framework to develop a differential and formulate an evidence-based medicine treatment plan. This lecture corresponds with Chapter 8 in your textbook, so please be sure to complete the reading assignment. Pharyngitis and tonsillitis are two common inflammatory disorders that involve the posterior pharynx. Inflammation can result from both viral and bacterial etiologies. Pharyngitis and tonsillitis may occur independently of one another. However, they often co-occur, sharing common etiology, clinical course, and treatment requirements. Pharyngitis and tonsillitis are one of the most common visits to a primary care provider. Most viral-related cases are self-limiting. Causes of viral pharyngitis include adenovirus, RSV, influenza A and B, Epstein-Barr, Coxsackie, enteroviruses, and herpes simplex are common viral origins. Viral infections usually present with mild to severe throat pain or the sensation of a tickle or pruritus in the throat. Viral infections typically present with rhinorrhea, conjunctivitis, and cough. Symptoms are rapid in onset, but systemic symptoms are few. Infectious mononucleosis, primarily caused by the Epstein-Barr virus, is common in adolescents and young adults. Transmission requires person-to-person contact between susceptible persons and symptomatic viral shredders. Mono is often referred to as the kissing disease for this reason. Mononucleosis is infamous for a gradual onset of fever and marked malaise with severe sore throat. Mononucleosis may present with exudative tonsillitis in 50% of the cases, in addition to palatal petechiae and rash. Anterior and posterior cervical lymphadenopathy are common, and splenic enlargement can occur. Diagnosis is made usually by a positive point-of-care monospot test, but in the absence of the availability of this test, a CBC will show atypical lymphocytes. It's important to note that this may not be observed, though, until the patient has had a few weeks of symptoms. Treatment is symptomatic and may take weeks to resolve. Patients should be instructed to abstain from contact sports or activities which may increase risk of splenic rupture. Now, the most common bacterial cause is from Group A beta hemolytic streptococcus. Identification of Group A beta hemolytic streptococcus is essential, as this can cause complications such as rheumatic fever, peritonsillar abscess, scarlet fever, or glomerulonephritis. Group A strep infections are most commonly observed in children 5 to 15 years of age in the winter and spring. Strep typically presents with an acute onset of fever and moderate to severe sore throat. Systemic symptoms may include headache, malaise, neck pain, odonophagia, and otalgia. The differential diagnosis for pharyngitis and tonsillitis should include Group A beta hemolytic streptococcus, epiglottitis, pharyngitis secondary to postnasal drip from rhinitis or sinusitis, hand, foot, and mouth disease from the Coxsackie virus, herpes simplex virus 1, mononucleosis, and stomatitis. On inspection, the inflamed throat typically appears reddened with both viral and bacterial causes. Exudates and enlarged tonsils are common findings in bacterial infections. Streptococcal infections may produce white to yellow exudate on the tonsils, a red tongue with enlarged papilla, commonly known as strawberry tongue, and a red swollen uvula. A sandpaper-like scarlatine-form rash may be present with a streptococcal infection. Herpes simplex virus 1 may reveal 1 to 2 millimeter vesicular lesions which can extend from the pharynx to the gingiva, buccal mucosa, tongue, and lips. Hand, foot, and mouth disease present with oral lesions co-occurring with xanthan on the hands and feet. There is a broad overlap of streptococcal and non-streptococcal, which is usually viral, pharyngitis, and the ability to diagnose group A strep pharyngitis based on clinical presentation alone is poor. As a result, testing for group A strep is unnecessary if the patient's clinical picture and epidemiological features are consistent with a viral etiology. And this would be presence of conjunctivitis, a cough, oral ulcers, etc. Blood work is rarely needed, but a CBC and monospot is recommended if diagnosis is unclear or if patients report close contact with a person infected with mononucleosis. Rapid strep antigen testing in throat culture should be performed on patients with pharyngitis who do not meet history and physical findings that are most likely associated with a viral etiology. Throat cultures are considered the gold standard in identifying the causative organism of pharyngitis and tonsillitis. However, a major disadvantage of the culture is the delay in obtaining results. It could take 24 hours or longer. Rapid strep antigen tests have a high specificity, 90 to 99% specific for detecting group A strep, and a high sensitivity. As such, a positive result means that it is very likely that the patient has group A strep. A negative rapid strep result should be backed up by a throat culture of the posterior pharynx for maximal sensitivity. The clinical features most suggestive of bacterial pharyngitis include a fever over 38 degrees Celsius or 100.5 degrees Fahrenheit, tender anterior cervical adenopathy, lack of a cough, and a pharyngotonsillar exudate. The presence of these four features, known as the Centaur criteria, strongly suggest a group A infection. Patients with greater or equal to 3 of Centaur criteria may be empirically diagnosed with group A strep and treated without further testing. However, empiric treatment of asymptomatic household contacts of a patient with acute streptococcal pharyngitis is not routinely recommended. Penicillin remains the treatment of choice because of its proven efficacy and safety, its narrow spectrum, and its low cost. Amoxicillin is equally effective and is preferable for young children due to its taste. Penicillin VK 250 mg TID or 500 mg BID times 10 days is effective. In clinical trials, once daily amoxicillin up to 1,000 mg maximum when dosing at 50 mg per kilogram per day has been shown to be effective and is likely to improve patient compliance due to less frequent dosing. An oral macrolide, clarithromycin, or azithromycin, is a reasonable alternative for patients allergic to penicillin. 10 days of therapy is indicated for all macrolides except azithromycin, which is given for 5 days. Treatment of viral pharyngitis due to mono does not include antibiotics. However, there are times when mono may not be suspected, as in the case of a positive rapid strep antigen test or a group A strep positive throat culture. When amoxicillin or ampicillin is given to a person infected with mono concurrently, roughly 90% of these patients will develop an erythematous macular rash. The rash coincides with antibiotic use and is often the first indication that the patient also has mono. It's important to note that this reaction is not an allergic reaction, therefore the patient should not be identified as having an amoxicillin allergy. Symptomatic treatment of both bacterial and viral pharyngitis and tonsillitis include analgesics and anti-inflammatory agents. Aspirin should be avoided in children. Saltwater gargling may be soothing for some patients. In severe cases, anesthetic gargles and lozenges may provide additional relief. Adjunctive therapy with corticosteroids is not currently recommended. Surgical removal of the tonsils and/or adenoids is absolutely indicated if tonsillar inflammation leads to airway obstruction or if active flares recur more than 3 times per year. Surgical treatment necessitates a referral to an ENT specialist. Peritonsillar cellulitis and abscess are acute pharyngeal infections most common among adolescents and young adults. Infection is virtually always unilateral and is located between the tonsil and the superior pharyngeal constrictor muscle. It usually involves multiple bacteria. Streptococcus and Staphylococcus are the most frequent aerobic pathogens, whereas bacteroides is the predominant anaerobic pathogen. Symptoms include gradual onset of severe unilateral sore throat, odonophagia, fever, otalgia, and asymmetric cervical adenopathy. Trismus, similar to lockjaw or hot potato voice, speaking as if a hot object was in the mouth, is common. Atoxic appearance, examples are poor absent eye contact, failure to recognize parents, irritability, inability to be consoled or distracted, drooling, severe halitosis, tonsillar erythema, and exudates can also be observed. Abscess and cellulitis both have swelling above the affected tonsil, but with abscess, there is more of a discrete bulge with deviation of the soft palate and uvula and more pronounced trismus. Patients should be referred to the emergency room immediately as maintaining airway patency and preventing sepsis is a concern. So this is an example of a peritonsillar abscess. Notice the displaced uvula from the abscess above the left tonsil. Now, let's take a look at acute laryngitis. Acute laryngitis occurs when the voice box or larynx becomes inflamed. Different conditions can cause inflammation of the larynx and include infections, chemical irritants, and allergies, to name a few. Common symptoms include weakened voice, hoarseness, and dry cough. The hoarseness or absent voice can persist for a week or more after all symptoms have cleared. This is usually a minor temporary condition. Patients should be warned not to strain or use their voice, as it can cause further damage such as hemorrhage, polyps, or cysts. Most cases of acute laryngitis are due to viruses, with Haemophilus influenza being frequently identified. However, the bacteria, Moraxella catarrhalis, has also been isolated in some cases. Treatment for laryngitis is supportive because it is almost always viral. Sprays, lozenges, saltwater gargles, and resting the voice can be helpful. Viral infections typically resolve themselves within a week. Finally, the last topic that we're going to discuss is bacterial tracheitis. Bacterial tracheitis is a diffuse inflammatory process of the larynx, trachea, and bronchi with adhering or semi-adherent mucopurulent membranes within the trachea. The major site of disease is at the cricoid cartilage level, the narrowest part of the trachea. Acute airway obstruction may develop secondary to subglottic edema and sloughing of epithelial lining or accumulation of mucopurulent membrane within the trachea. Bacterial tracheitis is capable of producing airway obstruction. One of the most common causes is Staphylococcus aureus and often follows a recent viral upper respiratory infection. Bacterial tracheitis is a rare complication of influenza. Patients may present with croup-like symptoms such as a barking cough, stridor, and fever. However, patients with bacterial tracheitis do not respond to standard croup therapy like racemic epinephrine, and instead require treatment with antibiotics and may experience acute respiratory decompensation. Bacterial tracheitis may be more common in the pediatric patient because of the size and shape of the subglottic airway. The subglottis is the narrowest portion in the pediatric airway, assuming a funnel-shaped internal dimension. In this smaller airway, relatively little edema can significantly reduce the diameter of the pediatric airway, increasing resistance to airflow and work of breathing. Diagnosis is usually by physical exam, but blood tests, X-ray, and tracheal cultures may be obtained in the tertiary setting. Treatment consists of appropriate airway support and antibiotics, and most patients with bacterial tracheitis improve within 5 days.